start off telling your instructor about how, with your chest tube patient, you're going to come in, you're going to do an assessment on them, listen to their lungs. You should hear lung sounds around that chest tube insertion site. They should be, in no pain, no signs of difficulty breathing, hypoxia, shortness of breath, any of those things. And of course, I've also done the routine, knocked on the door, wash my hands, ID the patient, all that good stuff. So once I've kind of done my respiratory assessment on them, checking for that tracheal deviation, making sure the chest rise is even, I'll zone right in here to their insertion site for the chest tube. Take a look at the dressing, make sure it's clean, dry, and intact. Palpate for crepitus, right, as needed. Make sure the tube is connected to the tubing system, right, and that's a good connection. Work my way down the tube, make sure there's no dependent loops or drainage issues. I can milk any clots, but I don't want to strip. And I'm going to lift this up on the table for demonstration, but I would not lift it up. In real life, it would not go above the patient. I would then take a look at the system and determine what kind of system it is. This is a dry suction system. It looks like it's actually been tipped because this isn't blue anymore. So I'd probably need to get a new one because it's contaminated. But assess that. Assess that this suction is set appropriately. I would explain how I would check for suction, which means that the bellows would be out. I would stop and say, okay, if this was a wet suction system, the difference is that it would have another chamber, which would be bubbling. And the level of the water would be how I knew what the suction was. Okay? So suction's good. Check over here for the water seal. If there's any bubbling, it could mean either the patient has a pneumothorax or they have a leak in the system. If I expect a pneumothorax because they've had a trauma or a big surgery, I just want to make sure that it's getting better, going away. If it's brand new leaking and I'm not sure where it's coming from, I'll come up to the patient with a rubber-covered clamp close to the insertion site. If it stops bubbling, most likely it's up here somewhere inside the patient's chest wall, or the tube has slipped out or something. If it continues bubbling, then I take a second clamp and I do this two-clamp thing where you can clamp like this, remove this one. If it stops, then that means it's in here somewhere. If it continues, then I go ahead and put another clamp right here, remove. If it stops, I try and figure out where it's at, right? These can actually be taped over if there is a leak or something in the tubing. The manufacturer says that. Most likely, though, it's usually coming from the patient or something's not connected. If it's disconnected, okay, so I come back up here and I look, and instead of being nicely taped up, this is like hanging out. There's a tube sticking out of his chest, and this is laying in the bed. Two things I can do. One is I can sanitize the end of this and reconnect it quickly because we want to make sure that he's not sucking air into his chest, right? I can also place the tube itself into a sterile water bottle to create an emergency water seal. At the same time, I'm hitting my panic button, calling for help, assessing the patient, looking at him, making sure he's doing okay. If I look and the tube itself is completely out of his chest, right? It's just laying in the bed. Again, gee, sir, are you feeling okay? Make sure he's all right, not showing any signs of a pneumo. Grab my Vaseline gauze, which you won't necessarily have for testing. You can just verbalize. You'll have Vaseline gauze. Cover the hole, call for help, it's an emergency, continue to assess and stay with the patient. I'm going to look at the output on this, document as needed, mark it and document it, assess the color and everything and that it's appropriate for the phase of recovery that this patient is in. Make sure the dressing has been time and dated and documented appropriately also. Again, if it gets tipped over, check the patient, make sure they're okay. You can pick it up right, obviously, but make sure they're doing okay. And then based on your facility or the system, you may replace the system if it's contaminated or something like that. And then, of course, you want to make sure it's back where it belongs. And then you would document your assessment of the patient, which includes the respiratory assessment, a pain assessment. How's he doing with his pain? Is he handling his pain okay? What the drainage looks like, how much there was that goes in the eyes and nose, how much the suction is set at, if there's an air leak or not. The newer systems can actually tell you how much the leak is, so you would document that. I think that's it. What type of system it is, whether it's wet or dry. So you have to be able to identify the different systems, and explain the two different kinds. Even if you only have one, talk about the differences between the two. Wash my hands, and I'm done. Did that cover everything on the checklist? Mm-hmm. Yeah.